Welcome to an Introduction to Eating Disorders for Clinicians. We're going to cover quite a bit of territory today, looking at why eating disorders are an important topic to consider, as well as the underlying biological and psychological factors that contribute to the development of the disease. We'll go over diagnostic criteria and also consider who is at highest risk and how to screen these individuals for eating disorders. This is the first in a two-part series, and in the second video, we'll cover medical complications and treatment. So, why is it important to talk about eating disorders? Eating disorders have tragic consequences for the patients, leading to increased morbidity and mortality. All eating disorders carry with them an increased risk of death from both medical complications and suicide. Anorexia is particularly lethal, with among the highest fatality rate of any mental illness. With 30 million people in the U.S. dealing with an eating disorder, you will see these patients in whichever specialty you choose to go into. For example, if you're going into peds, eating disorders are actually the third most common chronic condition in adolescents, behind only obesity and asthma. Patients with eating disorders present to many different specialties due to their increased risk from a number of medical complications. Also, we ourselves are not immune. Research has found as many as 1 in 5 female medical students may struggle with eating disordered behaviors, which can significantly impact our ability to care for our patients and enjoy our own life. Despite the serious medical consequences, these patients often fall through the cracks. We all have certain ideas about who will have an eating disorder. Most of us envision a young, emaciated, Caucasian teenage girl from a well-off family. But eating disorders affect all races, shapes, sizes, and genders. While some patients may show obvious outward manifestations of their illnesses, such as low weight, many do not, making detection more difficult. In fact, only 1 in 10 patients with bulimia are identified by healthcare professionals, thus delaying treatment, which is particularly problematic because earlier treatment is associated with better outcomes. As with any illness, if an eating disorder isn't on your differential diagnosis, you won't make the diagnosis. Eating disorders emerge from complex interactions between biological, psychological, and social factors. Cultural norms and pressures contribute to the development of eating disorders. We live in a thin is beautiful culture with an emphasis on a perfectly toned physique for both men and women. However, culture is not the sole driver of eating disorders. While over half of the nation goes on a diet in any given year, only a small portion of them develop an eating disorder, suggesting other factors are at play. Another big contributor is genetics. Eating disorders have a high degree of heritability, with rates from 50 to 75% reported in various studies, suggesting a strong genetic component. Research has implicated genetic variations in the serotonergic and dopaminergic systems, as well as possible alterations in the circuits involved in appetite and reward, that all may be involved in the etiology of eating disorders. Finally, there are a number of additional personal factors that drive the development of eating disorders. For one, many of these individuals have a history of trauma. Also, certain personality types seem to increase risk for eating disorders, such as perfectionistic, avoidant, or obsessive traits. Then, there is a significant role of comorbid psychiatric illnesses. Many of those with eating disorders also suffer from other psychiatric disorders, such as anxiety or mood disorders. Well, this can be a bit of a chicken or the egg situation. Often the other psychiatric disorder, such as anxiety, precedes the development of the eating disorder, suggesting that anxiety may actually be a contributing factor in the development of these disorders, or that they share common risk factors. Now we're going to take a quick tour of the 4 most common eating disorders. You can refer to the table online for more detailed diagnostic criteria, as I'm just going to hit some of the high points here. So, broadly speaking, what are eating disorders? The DSM defines them as a group of disorders in which there is a persistent disturbance of eating or related behaviors that lead to altered consumption of food and significantly impairs physical health or psychosocial functioning. That impairment piece is important. Eating disorders have a tendency to completely take over the lives of the individuals affected. The 2 eating disorders you hear about most are anorexia nervosa and bulimia nervosa. Anorexia is defined by an individual restricting their caloric intake such that they have a significantly low body weight. Typically, this is considered a BMI of less than 18.5 in an adult. These individuals also have an intense fear of weight gain and significant concerns about their own weight, shape, and appearance. Notably, amenorrhea, a common feature seen in patients with anorexia, is no longer part of the diagnostic criteria. Bulimia nervosa is characterized by discrete episodes of excess eating, coupled with a sense of a loss of control, along with compensatory behaviors, such as vomiting or other forms of purging. Like anorexia, these patients also have significant concerns about their weight and shape. Unlike the diagnostic criteria for anorexia, bulimia has specific time and frequency requirements. To make the diagnosis, an individual needs to be purging, on average, once a week for at least 3 months. If they're doing it less often, we put them in the generic and rather unsatisfying diagnostic category of other specified feeding and eating disorder in the DSM. The two diagnoses that are new to the DSM-5 are binge eating disorder and avoidant restrictive food intake disorder, or ARFID for short. As with bulimia, binge eating disorder is defined by discrete episodes where an individual eats to excess and feels out of control. Also like bulimia, there's the same time requirement, occurring at least weekly for at least 3 months. However, binge eating disorder does not have the purging behavior you see in bulimia. ARFID is a disorder that you most often see in children or people with autism spectrum, and it's basically picky eating taken to the extreme. Individuals with ARFID are not taking in enough nutrients such that they have significant weight loss, a nutritional deficiency, or may be dependent on tube feeds or supplements. You may be thinking, wait, in some ways this sounds a lot like anorexia, and you'd be right. But the key difference is the reason for the restriction. These individuals aren't concerned about their weight and appearance so much, but rather the very nature of the food itself and how it makes them feel. And they may eat, for example, a very limited range of foods and foods of just a certain texture. All right, so how do you go about making a diagnosis? I've told you that you'll see these individuals in practice, so what should you be looking for? This can be tricky, as very few people with an eating disorder come in saying, hey, I've got an eating disorder and I need help. I mean, it does happen, but more often than not, only when they're dragged in by a concerned family member. Instead, they come in for a whole host of other reasons that are related to their eating disorder, but for which the link may not be immediately obvious. Because the truth of the matter is that these patients don't volunteer information about their eating disorder. There's a great deal of shame associated with these illnesses, and often people are embarrassed to share just how impaired they may be. Also, these can be egosyntonic disorders that, on some level, the patient actually finds helpful. If you are focused 100% of the time on food, you can ignore the other issues in your life. Given these individuals aren't going to offer information about their eating disorder unprompted, we have to figure out who we should be screening and ask directly. Because the peak onset of these disorders is typically during adolescence, the American Academy of Pediatrics recommends screening all preteen and adolescent patients as part of their yearly wellness exams. For adults, it's most beneficial to screen high-risk groups. Eating disorders are most often developed by the time someone is a young adult, so think about it particularly in people under 30. However, I want to emphasize that this is not an illness just of the young. Some 13% of women over 50 have eating disorder behaviors. Overall, women are at increased risk, particularly those with anxiety disorders or those under stress. Anyone with a family history of an eating disorder, those who've had rapid changes in weight, or those seeking help for weight loss also merit screening. Finally, you definitely want to bring this up with athletes, particularly those in sports with an emphasis on body type or making weight, like gymnastics, rowing, and wrestling. So, what do you say when you actually screen? I start by normalizing it. Come up with what feels comfortable for you, but I say something like, often when people are under a lot of stress, they'll eat more or less than they would otherwise. Does this happen to you? Even if they say no, I'm still going to ask the screening questions, but this frames the whole thing as a response to stress, which can make it feel more normal. One simple screener is the eating disorder screen for primary care. Questions include, are you satisfied with your eating patterns? Do you ever eat in secret? Does your weight affect the way you feel about yourself? Have any members of your family had an eating disorder? Or do you have, or have you had in the past dealt with an eating disorder? Having 2 abnormal responses gives you fairly high sensitivity and specificity and merits further investigation. For those who screen positive or for whom you have additional concern, additional questions about eating behaviors, purging behaviors, and concerns about body shape and weight can help you better understand not just which disorder they might have, but also how severe it is. Also, asking questions about how the eating disorder is impacting their life offers an opportunity to express empathy and better understand whether they're willing to consider treatment. This brings up the point of rapport. These can be difficult patients to work with. They're often ambivalent about treatment, causing distress both for us as care providers and their families. Because of this, building a trusting rapport is critical to facilitating treatment. You want to convey a genuine empathy and curiosity while avoiding judgment, even of behaviors that can appear really illogical. It's also important to check your own emotional reaction. We all have certain thoughts and beliefs about patients with eating disorders. We also all have our own relationship with food, weight, and our own body, which can color how we interact with these patients. Talking with other providers, some express concerns about knowing the right thing to say to an eating disorder patient. So there is no one right thing to say, no magic bullet. However, there are certain approaches to take and things to avoid. These are some of the suggestions my own patients and I came up with when I asked them to give me advice to give to clinicians. First, do share your level of concern with the patient. Nearly all patients with eating disorders have a heavy dose of denial. Be honest about your concerns for their health while offering hope for recovery. As part of this, it's important to be honest about your diagnostic impression. If you're not sure, you can say so, but if you'll be writing an eating disorder diagnosis down in the chart, that should be shared with the patient. While they may be in denial on some level, many patients know that something is wrong, and sharing your clinical impression supports this. As you're working with these patients, they often have a lot of strong emotions. Rather than minimizing or trying to change them, validate those emotions that they are having. Saying something like, I can see that talking about your eating habits is really upsetting, but it's important for me to know how to give you the best treatment I can. Shows that you recognize how hard this is for them and yet need to keep pushing forward. Finally, take the opportunity to learn from your patient. Listen to what they're saying and what they're struggling with. One of my patients offered that she really appreciated being asked about her experience, and it made her feel much better understood. For an illness shrouded in shame, this can go a long way to supporting a therapeutic relationship and facilitating treatment. In terms of things to avoid, do not chalk this all up to needing to change their diet. Just advising them to eat more, unfortunately, will get you nowhere and alienate your patient fast. Yes, you're right. A patient with anorexia does need to eat more, but if you simplify this to being all about food, you've missed an opportunity. Don't underestimate the emotional distress the process of recovery can cause for these patients. This is genuine and often severe. Also, as the patient begins to recover, avoid making weight and shape comments. Things we're all inclined to say as a patient weight restores, such as, hey, you look good, or you look so much healthier, will simply be heard by the patient as, you've gained so much weight and you're fat. Finally, and most importantly, remember that this is a mental illness and not a choice. To conclude, eating disorders are a serious mental illness that result from a complex mix of biological, psychological, and social factors. Early identification is associated with better outcomes, so it is important to screen high-risk individuals. Rapport is essential to establish from the very beginning to facilitate treatment. In our next videocast, we're going to talk about treatment and recovery. Thanks so much for listening.